Hello, everyone, and welcome to the next session of CME Palooza Fall. This is our lunchtime session sponsored by Daiichi Sankyo. This session is entitled Implementation Science, Reimagining Solutions to Systems-Based Needs. It is noon on the East Coast, so it is lunchtime. So hopefully everybody who got one of our CME Feeds the People Grubhub gift cards is ordering their lunch to be delivered so that they will not miss this session. So as with all of our CME Palooza fall sessions, we'll start by acknowledging our sponsors, our gold sponsors, Daiichi Sankyo, Med Learning Group, and Physicians Education Resource. Our silver sponsors, the Academy for Continued Healthcare Learning, Academic CME, Antidote Education Company, Catamount Medical Education, DKB Med, Hippocrates, Helio CME, Integrity CE, Medscape Education, Platform Q Health Education, Prova Education, Red Med Ed, and Vindico Medical Education. And our bronze sponsors, Answers in CME, AxDev, Bonum Continuing Education, Creative Educational Concepts, CMEology, Excalibur Medical Education, Global Education Group, Infograph Ed, MedIQ, Partners for Advancing Clinical Education, Paradigm Medical Communications, Postgraduate Institute for Medicine, PriMed, PBI, RMEI Medical Education, and Right Medicine. Also like to acknowledge the sponsor of the CME Palooza Spectacular Challenge, which was Talem Health, for those of you who participated in that last week. So there are three ways to ask questions during this and all of our CME Palooza sessions. You can use the CME Outfitters text line to send in a question. The number is 267-6660-CME, 0263. You can tweet your question to us using the CME Palooza hashtag. And for those who are watching this on our live page, if you open up the viewing window on YouTube by clicking on the Watch on YouTube in the lower left-hand corner, you can enter in questions within the YouTube chat function. So we'll be monitoring all three of those mechanisms throughout this session and interspersing questions for our panelists throughout. So we'll be incorporating audience response questions during this presentation using Poll Everywhere. Thank you to our sponsor of the audience response system, Broadcast Beat Studios. So for folks who have not yet downloaded the Poll Everywhere app, please do so and join the presentation entitled CME Palooza 005, or type in the following URL in your web browser here on your screen, www.pollev.com/CME Palooza 005. We've got a couple of polling questions here at the beginning of the session that we'll be asking here in a moment. So finally, our speaker disclosure slide. Please note that the opinions, discussions, and or conclusions expressed are those of our panelists and do not represent an endorsement by or position of their employer, its parent companies, or their affiliates. So now I'm going to turn things over to John Ruggiero to introduce himself and have the panelists introduce themselves before we will move into our initial polling questions.
Surely, Scott, thank you so much. First of all, it's really great to be with all of you today. Scott, congratulations to CME Palooza once again. The immense amount of sponsorship that you're getting from this community, I think, speaks to the level of what you're providing here for our community. And I'm happy to be part of it, happy to be a sponsor as well, happy to be part of an organization that is actually doing the kind of work that we're going to be discussing today, too. So for those of you that don't know me, I'm John Ruggiero. I'm head of the Medical Proficiency Acceleration Center at Daiichi Sankyo, which includes the Office of Grants and Education. And I'm joined by colleagues of mine that I'm very proud to be surrounded by. Terry?
Hi, my name is Terry Bichet. I'm also at Daiichi Sankyo. Thank you, Scott, for having me on today. I'm really excited to be part of this panel and part of CME Palooza. I manage grants in lung cancer and gastric cancer education across Daiichi Sankyo, and I'm also partnering with John on implementation science, in which we'll be talking about today.
Hi, everyone. I'm Bob Stern, Managing Director at Kaplan North America. Previous to that, Projects of Knowledge founder and at Point of Care founder. acquired by Kaplan about a year ago, 11 months, and really pleased to be here with John and Terry. Thank you, Scott, and thanks to Daiichi for sponsoring this.
Okay, great. So thank you to all three of you for introducing yourself and for agreeing to serve on this panel. All right, so we've got a few audience response questions. So for those of you who have the Poll Everywhere app up on your phone, you can call it up. So here is our first question, and some people have already answered. All right, so if you are going down the shore or down the shore, you likely live in A, Philadelphia, B, New York City, C, California, or D, Miami. I will give you a hint. It's a little cold to be going down the shore today from this location. All right. So 56% of people think it's New York City, only 39% Philadelphia. Miami's getting no love. The correct answer, of course, is A, Philadelphia. Okay, question number 2. Because there was no implementation science, it took years for lemon juice, among other citrus fruits, to be introduced into sailors' diets to prevent scurvy. When did this miracle cure first become popularized? A, 1527, B, 1591, C, 1604, D, 1635. Answers are all over the place. I always said when I was just starting work, I really missed the days when people would get scurvy. It always sounded like something that was a lot of fun to get. All right, Bob, what's the correct answer?
The correct answer would be 1635.
1635. So the majority of people did get this correct. So very good. All right, one more question. And this one ties directly to this session. Which of these are the key characteristics of implementation science and research? Choose all that applies. You can choose up to 3 answers. Okay. Your choices are: seeks to understand more about real world or usual practice settings, uses a plan, do, study, act model to assess change, addresses how, why, and what is implemented and their effects, concerned with interventions at policy, program, and individual practice level, or developed at MIT in the 1960s during the development of the first supercomputer. So answers a little bit all over the board. There are 3 correct answers here. John, what are the correct answers?
Well, many of them can apply, which we're going to discuss today. Not particularly sure if it actually started at MIT, but the 1960s.
It did not.
Right. The 1960s is somewhat correct. Yeah.
Did not.
A, C, and D are the correct answers here. The plan, do, study, act is not implementation science.
It can be, though.
It can be, though? Okay.
Yes.
Okay. All right. So great. So now we're going to move into our presentation. And John, I believe that you are going to kick things off.
It is. And thank you again, everybody, for being here with us today. I know that you're seeing this slide and thinking, why is Brian McGowan on this slide? He looks good with his green eyes and his pearls and flowing hair. But what is he really trying to convey? And I think really what he is trying to convey and what it demonstrates is that the confusion and dazed feeling that we all experience when we're constantly challenged to keep up with change is sometimes overwhelming, to say the least. We all recognize that change is the only constant. And all of us on this panel, however, also recognize that when our community is consistently being asked to change, that itself is the overwhelming situation. But the best case scenario is really when many of us are already doing the work to address the changing needs of our stakeholders, but may not be realizing it. You know, the author, philosopher, ex-husband C.S. Lewis, just kidding about that, once asked, isn't it funny how day by day nothing changes, but when you look back, everything is different? And there's really something powerful in that quote. That's what we want to discuss with you today. We want to discuss something that has been around for decades and how there is a role each of us listening today can take, whether you're from industry or you're a provider or even from a hospital or larger health system, which I know several of you who are listening today are part of. So why don't we advance to the next slide, Scott, please? Because today we want to talk about our collaborations, but not collaborations in the spirit of collaborative RFPs between supporters or an RFP collaboration between supporter and membership groups or a hospital. We're also not discussing industry-led education today. There is an appropriate forum to discuss that increasingly debated topic. Again, that is not today. Our discussions on collaborations today are meant to be about industry collaborating directly with health systems, often with the assistance from a third party, which could be a provider. We also want to discuss how we define implementation science, which according to some literature did begin in the 1960s, but according to Scott, not at MIT. This concept evolved in the 1990s and early 2000s when health systems determined it was essential to de-implement inappropriate health interventions to minimize patient harm, maximize efficient use of resources, and improve population health overall. We've seen great examples over the past couple of years since we began using the term implementation science in our community, where IME relationships forged between a provider and a hospital use that term, and likely rightfully so. It is not our intent to suggest that the term may be being used inappropriately. It's certainly not my intent to coach anyone on how to do their business or name their business objectives. But instead, we want to give you the definition that health systems use for implementation science, as it is very specifically defined with specific institutional requirements that are quite different than independent medical education, and how industry is becoming a partner stakeholder directly with these systems in some aspects of the system's care planning. That's very important. But as mentioned, we believe there is a role that each of us can play in this discussion. So look, we recognize the session may not resonate with everyone, and that's okay. We hope instead, whomever you are, that you leave this session having been exposed to something new to explore. For those industry or provider departments where this may resonate, perhaps there's some things discussed today that bring forward different or reinforced perspectives that build better practices for all. So let's go ahead and begin with the next slide, because it's really important for everyone to understand that one of the driving goals of medical affairs departments within biopharma and medical device companies, which I'll term as industry moving forward today, is to accelerate evidence into practice. But beyond that, medical affairs is increasingly seeking to understand why clinical decisions are being made, not just what are the gaps, but why those decisions actually unfold and what are the barriers to those decisions. This often goes beyond educational gaps, but is discovered from tapping into initiatives that expose not just the preference-sensitive care gaps, but also the supply-sensitive healthcare business issues. So look, everybody, IME will always be a critical component for addressing the optimization of medical evidence and its acceleration into the care delivery process. But systems often need additional and complementary vehicles that extend beyond continuous learning and professional development. One example of many of those requirements, health systems are actually required by different regulating bodies to perform quality improvement-based assessments in accordance with the triple and/or quadruple aim, often with resulting time-sensitive research publication requirements. And they must accept the corporatization of healthcare, while evidence suggests around 56% of them are already overwhelmed. And while hospitals can work with anyone, providers included, to assist them with meeting these pressures, working with industry is a panacea, or in some ways a perfect remedy and cure-all for them, because doing so addresses joint needs. For example, expanding alignment with the system's ability to gain access to trials that they once may not have available to them, and future opportunities to even share resources, expenses, and assets. For industry, these collaborations allow for pairing the core value proposition, our molecules, for example, with technological solutions in terms of prevention, diagnostics, and treatment. It also helps the clinical community better understand that industry seeks to go beyond the prescription and instead be an equal stakeholder at the table in the population health decision making. So yes, IME can be quality driven. Yes, IME can follow Plan, Do, Study, Act. And yes, when it is absolutely relevant, supporters value IME that brings forward practice change. We're not suggesting to stop that. But the difference between how we are defining implementation science here today is the opportunity is forged through regularly occurring industry to clinician to health system conversations by medical account managers in pharma, and that the need is led by the health system. And the solution is co-designed by the health system and the industry partner, who will often bring in that third party, possibly again a provider, in a plan, do, study, action kind of format. So again, the implementation science need is driven solely by the health system, and for how we are defining it today, not an industry supported or provider driven grant activity. And that need is usually because of a system deficiency that is quite different than the IME objectives that we all are very close to. So to the next slide. Now Suzanne Murray, founder and leader of ACSTEV, is gasping, trying to make sense of everything that I just said. And actually, just so everybody knows, I'm teasing Suzanne and Brian because they actually know implementation science. They know how to define it in the way that we're doing today, and they do it. So to reiterate, yes, we encourage providers to submit grants that continue to change practice in a period of time that is relevant for the gaps, and we will continue to support those efforts. But for us today, the official term of implementation science, again, is very purposefully industry to health system engagement for very crucial reasons. So how so? First, it may be helpful to discern the commonalities and the differences between implementation science and independent medical education. So if we go to the next slide, let's just briefly examine two of the common stakeholders each of us in this community know and appreciate: the providers and the supporters. Once again, as a supporter, and speaking for Terry, who is also a supporter, we would be nothing and nowhere without the incredible contributions providers bring to clinicians. We also respect that many providers have a mutual feeling toward industry, hopefully, because without the science, educational content couldn't be available. So it is a love fest of sorts, and I actually mean that in a very compliant way. You all know the responsibilities and skill sets for each of the stakeholders in IME. Well, let's hope that we all know that, because if we don't, we've got a problem. But let's examine where the roles shift in responsibilities and skills when it comes to implementation science. Just starting very specifically with the supporter stakeholder and implementation science. This goes beyond the art and very skill-based process of making decisions on grants. It requires somebody who is strategically aligned to what medical and even commercial account leads need and how they identify specific systems for interaction between industry and that particular system. It also requires somebody who is very acute in knowing cognitive and emergent sciences, somebody who can actually account manage a program in collaboration with the other account managers in the organization, the ability to address needs that go above brand, but how to tell the story internally so that we recognize the important reason why we are collaborating with this health system in the first place. And it also is somebody that has the ability to bring outcomes to a quality payment program centric kind of format, because that is what is really important to the health systems, especially if they're part of a quality payment program. Hence, not necessarily QI education, but quality implementation improvement. If you look to the provider side of the stakeholdership, we call them, when interacting with us in implementation science programs, vendors. And why do we do so? It's not to belittle the power that you have as an accredited educational provider, but it is because more than likely you are accredited. And we do not want to muddy the waters or blur the lines of compliance between that which is independent and that which is collaborative. So in that sense, there is a comfort in partnership, but sometimes these vendors have to get used to leading from behind. Because the collaboration is with industry and the health system, that behind leading is part of a third party relationship, whereas in the IME space, providers are used to doing this on their own, and rightfully so. Okay, the other thing is we really seek providers and or vendors who have the ability to have interoperable systems with a health system's EHR. Very important, because often the pain points that the health system addresses could be captured and being measured in the EHR, and the interoperability is an easy way for them to be able to gain access to real-time data on the progress the implementation science project is having. They need to know CMS regulations, the quality payment measures, and also a differentiated experience in focusing in those equality payment programs. So I know I threw a lot at you, but what I'm going to do next is transition over to Terry so she can actually show you some real-time examples of everything that I just mentioned. Terry?
Thank you. So as John alluded to, it's becoming an increasing goal for both health systems and pharma to really examine the patient care to optimize the patient experience as well as patient goals. And really, that's the center of all of this. And oftentimes the pain point of a health system is very different than the goals and objectives set forth by IME in both emerging, existing, and established evidence. And while that's very important too, the pain points are usually very different when we're talking about implementation science. And here's an example of an oncology-focused collaboration. And the reason I'm focusing on oncology is because that's the area in which I work. However, there are also other areas that would be applicable. So for those that are not working in oncology space, alternative payment models within the CMS quality payment programs that also look to mitigate risk would be applicable as well. But if we think about oncology focus, the OCM is about to retire with the EOM, or the Enhancing Oncology Model, taking its place. And really the center of all of that is to better support patients and improve their care experience. So if we think about the triple aim that John had mentioned earlier, it's really about integrating patient preferences into the clinical decision. So that's number one, improving patient experience, and really that shared decision-making. So between the patient and the healthcare professional, and even more so than shared decision-making, but really informed decision-making, allowing the patient to be part of their journey and making their voice heard through their journey and incorporating any of their preferences through the treatment. Second would be really concordance with guidelines. So as the guidelines continue to change, especially in the field of oncology, where data is rapidly evolving and rapidly coming out, it's really important that health systems are concordant with guidelines and are really optimizing the clinical guidelines and system pathways in a very timely manner. So today and not tomorrow. And then lastly is really reducing unnecessary rehospitalizations. So as John had mentioned earlier, quality-led based learning programs for both the clinicians and patients. And this is really about, making sure that any type of side effect management is really utilized by both the HCP and the patient. So having the patient understand the common side effects that could occur with their treatment to really reduce unnecessary rehospitalization, and also in a terminology that they can understand and that they can grasp and that they can communicate to their health system. So if we move to the next slide. So this is really a schematic of how implementation science works. So first, we ideate with the health system. They come to us, as John had alluded to, they come to us. The pain point is usually communicated with a health outcomes liaison, a medical liaison, or a commercial account manager. So they're usually the ones that are in communication with the health system. Then they come to us with ideas on, ways that we can help work with the health system to come up with a solution to really address the pain point that the health system identified. And this is, once again, hand in hand. And what I really want to draw your attention to is in the middle of the diagram, together we can. This is really about collaboration for the ultimate goal of optimizing the patient outcome, to really enhance the patient outcome and to make the patient the center of it all. So we would co-design a system-wide learning initiative, and I'll be discussing an example on the next slide. And this is where we would partner with what John had mentioned, a vendor, or otherwise known as a provider, but really a vendor in the sense that this is not IME driven. It would be a collaborative effort. And we would launch the learning practice for HCPs and patients. And after that, we would also implement some type of measures. So we could measure the progress that's being made from this learning initiative. And we can also implement any type of course correction. So if we see that the measures are not being met, we can also apply any type of course correction as needed so that it's satisfying the system's needs. And then really the ultimate goal is to co-publish and co-present. And why is that? We want to make sure that the findings that we come from this health system collaboration or from the implementation science is shared with the clinical community. So if another hospital or another health system is experiencing a similar pain point, they can learn from what's being published and what's being presented and apply it to their health system as well, and also re-explore. So this is just one way that we can really take that evidence that is being established through clinical trials and accelerate it into practice. So if we move to the next slide, just want to give you an example here. So this is something that is currently an implementation science project that we're working on at Daiichi Sankyo. So we're not going to name the health system here because it is an ongoing project. And I know that the diagrams within the slide are tiny, but that's okay. I'm going to walk you through exactly some of the steps that we've been taking through this project. And I just want you to keep in mind that schematic that I showed on the previous slide. So this health system in the Philadelphia area had come to us with a pain point. They have a very well-established welcome center, but this welcome center was being underutilized for various reasons. Some of the reasons that it was being underutilized is the actual brick and mortar status of the physical building. And especially with COVID, not a lot of the patients, I should preface, the welcome center were for cancer patients that were diagnosed. And it really served as a place for patients to get resources, to get programs that could assist them with their treatment journey, and also provides a respite and support for caregivers. And this, unfortunately, this welcome center wasn't being utilized. And a lot of the reasons as to why it wasn't being utilized was, as I mentioned, the brick and mortar status. With COVID, a lot of the patients didn't want to go to a physical building. Secondly, they actually had virtual programs, but the patient really wasn't aware of the virtual programs that were actually taking place. And a lot of that was because it was patient driven. It wasn't a clinical team that was actually prescribing the experience. It was really underutilized for those reasons. And so they wanted to increase the utilization of the Welcome Center, which was one of the pain points. But really, the bottom goal or the end goal was really to increase patient experience. They wanted to not only maintain their patient satisfaction scores, but they wanted to enhance them. Their patient satisfaction scores were good, but they really wanted to take them a step further. And if we think about the EOM model that I had referenced, that is going to be incorporated and taking over from the OCM, the patient is the center of it all. It's really about the patient-reported outcomes, making sure that the patient feels like they're being heard and that their needs are being met through their care journey. So the first thing we did was we ideated with the health system around ideas on how to satisfy this pain point. What are some ideas that we can implement to help increase the utilization? Secondly, we partnered with a vendor, but not a vendor in the traditional sense. It was actually a branding agency to really rebrand the Welcome Center, the brick and mortar building, as well as the virtual programming, and to redeploy it both on a community level, a national level, and an international level. This was coupled with also where John and I came into play is really to how could we increase patient satisfaction? There were virtual programs that were just not being utilized, but how could we make it really specific to what the patient was experiencing through their journey? One of the things that really resonated with me when we met with this health system was when a patient gets diagnosed with cancer for the first time, they may not be ready to accept their diagnosis and to dive into the resources they have available. So how can we engage the patient through their journey and really provide them resources at multiple times of engagement, multiple opportunities for them to engage? So we are actually deploying a strategy of using nudging science to really customize useful information in digestible nuggets for the patient, really around disease state information, what to expect, like symptoms of their disease state, what to expect with treatments, mental health resources, how to cope, how to talk to your children about cancer, or how to talk to your loved ones about their cancer diagnosis. And then we're also implementing measures along the way. So we want the goal is to make sure that not only are we sharing the progress with the health system throughout this experience, but that we also show a statistically significant increase in the utilization of the Welcome Center, and that we also think about the patient. Is the patient increasing their satisfaction? Are these resources helpful to this patient? And did it elevate their outcomes? So we're really in the process of doing this now. But one of the key things that I want to just draw your attention to is that this project is really about the patient and really elevating the patient and collaborating with the health system to really help them achieve their goals. And the other important thing is really partnering with a vendor that John had mentioned that really understands the quality payment programs, the EOM model, the retiring OCM model. And this is really a segue to turn it over to Bob to walk us through what Kaplan, powered by At Point of Care, can offer the community as well.
So Terry, before we turn it over, there's a question that came in on the CME Outfitters Q&A line that I want to throw your way. So the question is, how was this health system selected, and did they approach you, or was this something where Daiichi approached them?
Terry, do you want me to take that, or would you like to?
You can go ahead. You can take
it.
Sure.
I just wanted to reiterate something that Terry had mentioned. The system usually approaches us through conversations that regular medical account managers have with either individual clinicians or systems. I mean, these are regular current conversations that all industry takes part in. And when they have these conversations, usually something like this unfolds. A health system may say to them, look, medical science liaison, love you, respect you. I don't want any more data. I'm already swimming in it. Or, you know what, commercial and market access, I don't want to talk about formulary right now. We have a director of pharmacy that actually is primed to discuss that with you at the right moment. What I have is a current pain point that if I do not address, I'm going to face penalties. And the rest of the system is going to face penalties. We don't know what to do. We're in the business of directing patient care. We're not in the business of corporatizing or democratizing healthcare as we know it as a business. We need your assistance. So if you have a team that can actually collaborate with us and get this done, we're all in. So that's usually how it unfolds. Do we have specific accounts within industry that we prioritize for business needs? Yes. And the reasons for those prioritizations are different on the medical side than on the commercial side. But usually it unfolds from those medical account managers having conversations, learning through them that they want something more, and then bringing somebody like Terry and me into the conversation. Does that help, Scott?
Okay, great. Yep. Okay, that's the only current question we have, so I'll let Bob take the floor.
Thank you. Next slide, please. So next slide, please. So thanks, Terry and John. I think there's a lot to unpack here. It's a very big ask of a vendor. I'm going to get used to that word vendor, but I think it's an appropriate word because we're putting the engine behind what is needed to get done. So we see ourselves as health system engineers. We've been doing this for about 6 years now, working with various health systems in doing the implementation science. So we are very focused on several points that John brought up and then Terry brought up. I mean, it's about behavior change. It's about the feedback loop. It's about the gap and pain points. And how do you turn the science into practice? And of course, the transparency of it all. So let me get into some weeds here with everyone. If I can have the next slide, please. So I'm not going to really go through this entire list, but this is kind of the checklist of what the vendor is doing. So we stand as the gears to put all of this into motion with the health system. Sometimes we're contacted directly, or as John mentioned, industry is identifying the health system, but it requires a lot of back-end electronics as well as back-end data management in order to make this work. It's not just about working with the practice. I might use an example of multiple sclerosis, where it drills down to the actual practice level with the patients and the physicians. So because of that, and because of the data exchange that's needed to be done, there has to be a very cyber secure, high-level engineering product behind it that can handle all the different data requirements and the rigorous processing and the analysis of what is going on between the patient and the physician. Because without the rigorous analysis, you don't really know what is going on, and there is no decision point. There's no decision point where you get some view into what the physician is doing in reaction to what the patient need is, and vice versa. So get a chance to look at this slide. I'm sure we can share it with you. We're happy to partner, by the way, because this is a large lift. We are happy to provide the engineering behind what is needed for this. Next slide, please. So in basically a graphic overview of what we're doing is that, and that kind of goes to the previous slide and all the checkpoints there, is that what we're providing is the communication between the patient and the physician. And that is an ongoing patient communication process. There's AI and natural language involved in this. What you're seeing on the screen is our connection into an Epic EMR. We are a partner with Epic. We are a partner with Cerner. They probably own 70, maybe even 80% of the market. And as John mentioned earlier, you do need that connection into the EMR, because that's where the physician spends their time. It's where the physician gets their information. For the patient, we supply a patient app in the very particular specialty or the disease area that we're working in. This patient app gathers information in between office visits, which allows for a lot of information coming in to the physician. We do not supply this information just on demand by the physician. We allow the patient to share the information. So the patient is in control of sharing the information that they are gathering in between office visits. And it's not just diary information. We take in all Bluetooth devices. So if you're wearing cardiac pacemaker, you're wearing any sort of a Bluetooth device, we take that information in real time. We create it into charts, kind of have to squint in order to see it on the screen, but we create everything. We display everything in charts so a physician can read that information really in a matter of seconds and be able to intervene with the patient. So we have established a direct bidirectional communication with the patient and the physician, and this is what empowers the process for those in industry to be able to analyze the data and see what's going on with the implementation science. What are we implementing? We're implementing research and science into practice. I mean, that's what we're doing. That's what John and Terry are doing. We're acting as the as I said before, the engine that's putting all this together. And then, of course, we're analyzing this. So behind all this are implementation scientists, as we call them, that are facing to the implementation scientists on the health system side, and then the data analysts that we also have that are scrubbing this data and presenting it in the various ways that we and others may want to look at it. And then, of course, tweaking this along the way. So what you're really doing is giving an opportunity for the practice to not just take something that's dumped on them, but participate in the how this is going to be implemented and how the patients are going to react. This is a 1.5 to 2.5 year process sometimes. This is not a short-term engagement. This requires a great deal of analysis, and then at the end, then there is publishing. Next slide, please. So in the end, we're doing something like this. We are going to be presenting at San Antonio Breast in December, one of our implementation science projects, and that is kind of the loop that Terry was discussing, where it's really a full loop. You go from ideation to publish, and let's see what's going on with this and how we can be helpful to others, right? There are other pain points exactly the same as in this case, working with Yale and their breast cancer group, but there are others who have exactly the same pain points, and through the publication, we're able to help them and inform them, and Terry and John can help and inform them. So that's really the what we're doing in the weeds to make this work. Thank you.
Thank you, Bob. Scott, I think that you might have some questions of either your own or from the audience.
Yeah. So Bob, I guess that my first question here's for you, and this is just out of personal curiosity. So how many of these abstracts presentations are you guys giving during the course of, let's say, a calendar year, and how have they typically been received?
So it's a good question. I mean, it takes, as I said, it takes about 1.5 to 2 years to get to the point where we're submitting an abstract. It's a few a year. It's not a lot. It takes a long time to get to this point. Of course, working with the department and the physicians that we're working with. So it's a couple of 2 to 3, I would say.
Mm-hmm.
Okay. And so John, I guess John and Terry, I guess this question came over the See Me Out There's Q&A line. So how many of these implementation science programs is Daiichi and your team kind of currently working on?
Yeah, so Terry, I don't mind you jumping in here, but very much like what Bob said, this is a very methodical, mindful, and careful approach. You can't take on too much because you want to do it effectively, and it is long term. Like Bob said, any given engagement could start, and it might take anywhere from 1 to 4 months to even align with the system on what the exact pain point is and how to address that. And then another 4 months to actually design something that everybody feels really comfortable with. So it could be an 18-month process. So typically what Terry and I will do is we'll prioritize what are the 3 main gaps each year that we're hearing commonly being expressed across system conversations. And we try to engage in 3 specific projects one for each one of those gaps. It doesn't always perfectly work out that way, but in a perfect model, that's kind of the vision, because that's how much we can actually take on at the time, right? Just don't forget, there's a lot of work to this, like there is for IME as well. But because of all the different engagements, because of IRB approval, because of quality improvement technologies and health improvement technology systems that have to be addressed, and because of all the C-suite and the health system that has to align with this, it is quite a lift.
Yeah, and if I could just add to what John was saying, when we collaborated with the health system, the ideation period, like John mentioned, I would say it was closer to 4 months. It took a lot of back and forth with the health system to really figure out why the center wasn't being utilized and why the virtual programming wasn't being, utilized. Some of them were just the fact that how long the programs were, and really to get on the calendars with the health system took some time. As you all know, they like to term it in the health system as compassion fatigue. They're overworked. They have a lot on their plates. So they're really looking for time to spend with us. And so it's really trying to get on their calendars, which can be difficult at times, but really trying to make their job easier by satisfying one of these measures and these helping them with this pain point. But the ideation period could take quite some time.
And
the IRB.
I'm sorry. Go ahead, Bob.
So the IRB period alone can be 4 or 5 months.
Absolutely.
We're writing the IRB, but we're coordinating with, and even though this is not drugs involved in this, they treat it, most of the institutions treat it that way. So we're going through the same rigorous process. So that's why this could be 1.5 years to 2 years from beginning.
Exactly. And Terry just mentioned something that just reminded me of a critical point that I wanted to share with all of you. So not only is the ideation on what the pain point is and what the solution should be happening in that 0 to 4 month period, or sometimes beyond that, it's also aligning on what the measure is, what we believe the measure of success is going to be for them, and then them telling us what their measure of success is. So for the example that Terry provided with the system in Philadelphia with that Welcome Center, their main goal was increasing utilization and overall patient satisfaction. We recognize that. And also we recognize the important goal of, if they're happy with all the progress that's happening month to month, that's a great outcome too, because that means something for us as industry with collaborating with them. But then on top of that, we also have to identify, well, what else is deeply embedded within their needs. For example, they're an NCI designated center, but they're trying to maintain NCI comprehensive cancer designation. So everything we do here also has to incorporate what are the required measures of an NCI designated comprehensive cancer center, so that we can help them address that as an institutional goal through this project if they want to take that, which they do. So there's a lot of thinking that goes behind this. Terry mentioned something about nudging science, which is part of this particular project. That's really crucial to be developed really well as well. Because what Terry and I had to do was, let's just say that you want to focus on gastric cancer or GI cancers in general. In a 6-month care episode, how many times does a GI patient, on average, have an encounter with a clinical team in that 6-month period? And then we range that out and we try to adapt that to the nudges that they're going to have every time they're prepared to go to an encounter. So there's a lot of details that we can't do on our own. It obviously requires a third-party vendor to help us with this too. But a lot of, I don't want to say complications, because it's a really interesting and challenging, wonderful, positive experience, but a lot of details that go into this that have to be very methodical.
Now, one of the topics that actually came up in our last session on quality improvement was kind of the importance of being prepared that the specific individuals, specific champions of this project at the centers you're working with may not be there for the entire duration, and you may lose, one or more of the people who are really kind of the driving force at that institution. So how do you proactively kind of prepare for that to make sure that these projects, once they get going, don't just kind of crumble when some of the key stakeholders may not be in the same position that they were at the start of the project.
I think that's a really good question. Bob, you've had some experience outside of any collaboration with Daiichi Sankyo as well. I'm sure you've encountered this. What are your thoughts on that?
So we try to bring everyone into it. So we try to bring the care team into it as much as possible, so that if someone does leave, we have actually not had that problem, interestingly enough. So maybe people didn't want to move during COVID, but we've not had that. And it's an interprofessional team, at the system. So we also train the nurse practitioners who are in the practice. So we train PAs as well. We have a very broad interdisciplinary team within the practice, so that if that were to occur, there are enough people to carry on. And we're the glue. So we are the glue that continues as well, with the new team that's coming in and reorienting them. But with the bandwidth of the full team, we really don't see any issues with continuing, but it's a good question.
And I want to add on to something that Bob said, and this is where it's critically different than IME. And I want to drive home the point again. Many of these systems who are interacting in these collaborations with industry are doing so because they're part of a quality payment program. They have an incentive to operate in this manner, because if not, they will be penalized. So despite who is part of a core team that is very carefully designated by both the health system and by the industry collaborator, Daiichi Sankyo in this sense, there will always be somebody, despite change, that will be assigned the responsibility to improve the problem that the system identified. So that keeps everyone embedded into the conversation and a project not falling through the cracks. I don't know if Terry, you wanted to add anything.
Yeah, the only thing I was going to add for this specific example, the head of the oncology department first met with John and I, and he hasn't shown up to all the meetings, which is understandable. But really what we noticed was like the patient navigator and the nurse navigator, social workers, like a lot of those departments, they were really all involved, since they're the ones that day-to-day deal with the patient. And really it was about kind of like the point of entry, like how could we get this utilized most frequently, like who meets with the patient the most. And it was really, that nurse navigator, the patient navigator. So we often meet with them more so. And like John said, and Bob said, it's a team of individuals. So it wasn't really exactly the first person who brought it to our attention, but it was kind of the team that was involved in a lot of the collaboration meetings.
Okay, great. Well, that's the last question we have. So I'm going to wrap things up just to remind people that if they are watching the live version of this or they're watching the recorded version of this, there's a survey link at the bottom of our live tab that helps us plan for the future of CME Palooza. Only a few questions, so it can take you more than 5 minutes. And for those people who like money, or those people who love money, we're doing the CME Palooza scavenger hunt. So please go to the website of this special promotion sponsor, which is Broadcast Beat Studios, www.broadcastbeatstudios.com, and poke around and look for the CME logo. It's there somewhere. I had my family poke around and look for it last night. They eventually found it. So click on the logo and see what happens, and maybe you can be a winner. And with that, I would like to thank John and Terry and Bob for their participation in today's session. For those folks who are sticking around to watch the next session of CME Palooza Fall, just look on our live page and click the appropriate session link. It will start shortly here at the top of the hour in about 5 minutes. And just as a reminder, the archives of all of our sessions can be found on our agenda tab. And thank you to our archive sponsor, Array. So thank you once again to the three of you guys, and thank you to everyone who has been watching, and we will see everybody back here soon.
Scott, can I mention one thing before you stop?
Sure.
If anybody has any questions, wants to learn more on how to evolve your own team into this kind of thinking, or how you would get involved as a third party, or anything that we can clarify or address, I think you can contact any one of us. We'd be happy to elevate the conversation into a space where it deserves to be elevated. And clearly, Bob and his team have been doing a lot of this work outside of any collaboration with us. So we're just here to help. And we just hope that it just elevates the conversation on better patient care. And Scott, we really thank you for the time.
Oh, great. Thank you so much, John.
Scott.
Thank
All right.
you.
Bye, everyone.
Thanks, everybody.
Bye.
Bye.